I think it's important for us to again look at the role. I mean, because you represent clinical officers within the entire, medical spectrum. But I think it's important for us to look again at the role that clinical officers play, because that would then help us see on a broader, picture why then it is important to make sure that they're able to keep playing that role.
Very well. So clinical officers are health practitioners. We are found in around 87 countries across the globe. Some people think that clinical officers are only found in Kenya.
And they only trained at KMTC.
Yeah, we are called primary level clinicians. Albeit we have different titles. Actually, our count is 34 different titles for the 87 countries. And that is one thing that at the international level, because we have an association, we are trying to harmonize the nomenclature so that we have one title. The other thing I can say before even stating the role is that the US and the UK benchmarked from Kenya to start their physician associate program.
That's what they call it.
Yes, people are used to thinking that it's only Kenya that can learn from Europe and US. When they were benchmarking, I was in that meeting. They even took our curriculum and it is being implemented there. So that is the equivalent of clinical officers in the US and in the UK. So clinical officers, we usually work as primary clinicians. Primary clinicians means the first clinician you are going to meet when you get into any hospital. When you go to level 2, level 3, we are the only clinicians there. When you go to level 4 up to the level 6, mostly you are going to find us in the outpatient and in the specialized clinics and in theaters, depending on the specialty. So when I talk about the specialties, we have around 20 of them. Things like ophthalmology and cataract surgeries, 98%. If you have an ophthalmology or cataract surgery, 98% chances that is a clinical officer.
Okay.
Things that to do with the ENT, ear, nose, and throat. Things to do with anesthesia. When you have to be anesthetized for a surgery to be done on you, there is a 95% chance that that person who is doing that is a clinical officer. The same for oncology services. We are the ones with the specialists. If you go to oncology centers, the specialists you are going to find they are giving you chemo and the other things is mostly a clinical officer. I think for a long time we have not had that specialty for doctors. Probably it's the first, they're having the first class or the second. It has been the clinical officers. And the same for the other many specialties. So when you go to the HIV, TB clinics, when you go to the NCD clinics, the people that you're going to get there, a majority of them will be the clinical officers doing that. And with the new system, now with the new referral system, where you have to go to level 2 or level 3 before you are referred, 100% of Kenyans now have to pass through our hands before we can refer them upwards. So that is the scope of our role. And now you can imagine when that type of a cadre is locked out of the social health insurance, and then you tell Kenyans, can you prescribe to this insurance so that you do not pay?
And you see, when you talk about the importance of clinical officers in our health sector, please remember that since devolution, they've had 100 strikes. That tells you they've not been listened to 100 times.
So what makes it possible that they would listen at go 101?
Yes.
The unfortunate thing with this country, number one, we are very superficial. We have what I like calling superficial politics. Don't look for it in any dictionary. It is not there. But the superficial nature of it is we are only disturbed by what seems to threaten our image politically. And that is why it is only the strikes that are working. They do not work because these guys want to work. They work because people feel that they are threatened. Their image is being threatened. But as long as you do not do that, and that is why we always do letters, the correspondences, they don't care. They don't even answer. Until you threaten their positions, you threaten their comfort, that is when they are going to act. And everything that we have gained, I must say, since the 2010 constitution, before 2010 constitutions, we were like the military. We were not allowed to strike. We were not allowed to have unions. Since 2010, we have gained a lot. And by saying we have gained a lot, I'm not only talking as a clinician, I'm also talking as a patient. Because at one or the other time, I'm a patient, my child is a patient,
Indeed.
my relative is a patient or my friend. We have been able to improve so many things. We have improved the number of clinic officers that we have in the system. Of course, we are not doing very well because by now we are supposed to be 22,000 in the system. As per the statistics from the Ministry of Health, not from the union, though we are only around 7,000. So it means every one clinic officer works for 3 clinic officers. And that is why you'll find, at some point we looked at the Nakuru PGH, and we found a clinic officer had seen 150 patients
In a day.
within 12 hours.
12 hours.
And that is pure witchcraft.
It's something on drugs, that's for sure.
And if you don't
No
do
pun
that,
intended.
the MCA will be there slapping you.
Yeah.
Everybody will be on your case. Why aren't you using patients? And the problem is because in a day, as per the WHO, if you give a patient, you are supposed to take at least 15 minutes with a patient so that you can listen to them. You can be able to diagnose them without, when you're not in a hurry, so that you get it right. You're supposed to only see between 35 and around 45 patients. This person who is doing 150, I can assure you by the time they were getting to 60, they were fatigued.
Because look, if we do the math, Peterson, if you're
Yes.
saying that you're supposed to spend 15 minutes with a patient, and if you're doing just 100 patients, okay, I'm even saying just 100, it's ridiculous. 100 patients at
Yes.
15 minutes
Yes.
is 25 hours.
Yes,
It's more than a day.
it is.
So, two things are happening here. Either you're rushing through and you're not getting a full, comprehension of what's going on with the patient, and there could be things like misdiagnosis,
Yes.
or you are not seeing the number of people that you should see. So, how do you even begin to do 150 is more than 25 hours?
Actually, there's a problem.
There's a big problem.
The moment you're talking those numbers, you are going to misdiagnose.
Yes.
You are going to misprescribe. There's so many things simply because of fatigue.
Let's talk about when you're not even you as an individual, when you haven't gotten enough rest.
Yes.
You're not at your optimum.
True.
So this is a space that requires you to be at your optimum in order to see where there's a problem based on what somebody has told you, and then you then go ahead and diagnose. So we're dealing with a pressure cooker situation here where clinical officers around the country, for number one, not enough in terms of numbers.
True.
Number two, have to see the health burden is already so great. And you don't have the time or the resources to deal with everybody as you should. If we're dealing with a today problem where every clinical officer is seeing between 100 and 150 patients a day, that's a disaster.
And then do also remember that they're dealing with patients. The things they go through alone requires you to rest.
Oh no, we don't even
Mental
deal with
health
things that
and
they're going
whatnot.
through. We don't know, please. We don't have time.
Nobody
to,
cares for
We
the
don't have
carer.
time to think about what the carer is going through. That's not your problem.
And that is why politicians will never come to the public facilities because they're the decision makers and they understand these things. They know that the people there are fatigued. Probably they are going to misdiagnose you. They do not misdiagnose. They do not do medical errors because they are incompetent. They do medical errors because they are fatigued. When you are fatigued, there are several symptoms and signs you are going to have. You'll become irritable. Have you heard people say that our nurses are very rude?
What are you talking about?
They
Just
slap
the other
you.
day, we heard a story of a gentleman who arrived at the front door of a facility with a broken leg, and the lady at the front desk was literally watching him. Her eyes were open. If you looked at her, you would imagine that she was alive. But there is no life behind those eyes.
Yeah, and sometimes, as much as I am not supporting the rudeness and the other things, when fatigue sets in, even if you are to do a simple Google search about the signs and symptoms of fatigue at work, you see irritability, you see mental cloudiness, you see many other things, including stress and depression. And this is what our nurses also are suffering from. This is what many of the clinical officers and other health workers in public facilities are suffering from. And we are trying to tell them that we should stop looking at health workers as a liability. We should start looking them as a development. And there is an opportunity actually with the Social Health Authority, because right now, if you have more health workers, it is going to give you more money as a county. And this is the reason. The way we have oriented our social health insurance is such that the patient has the power and has the discretion to look for quality. So the patient is allowed to go to a level 2, level 3 of their choice, whether private, public, or mission. So the patient will follow where the quality is. And the money is going to follow the patient. And so if the public facilities, because patients will not go to the public facilities. In level 2, you only find a nurse. In level 3, probably a clinical officer and a nurse. You don't even have a lab tech. But if we can have at least a clinical officer per dispensary, the nurse, then you have a laboratory technician, so that at least you can diagnose quite well. You improve the quality of the diagnosis and management at that level. You are going to pull patients back into the public facilities. They will be followed by that money that then you are rebated by SHA, and you are going to get more money for FIF. You have an FIF bill where you are supposed now to retain that money at the facility level for the improvement and buying the equipment. And with time then, that is going to build the health system in the public sector and make it better. So there is an opportunity, and employment of more health workers at this point is evident that it's actually a development, not a liability. But then our politician sees that as a liability, and that is why they want to minimize that cost as much as possible. And in our return to work agreement, that is one of the issues, and it's one of the issues that we are also discussing. But then the problem is that from our PFM Act, the Public Finances Management Act, the capping of 35 for the recurrent expenditure, and then you push the employees in that 35%, and keeping in mind that when the devolution was happening, counties had only been given money for the employees. So at some point it was actually almost 100% when they were starting. And a bigger chunk of the money goes to employees. So you'll find most of them have surpassed that. It becomes an audit query. And that is why we are saying that there needs to be a revision on how we look at that. Either we categorize health workers as development expenditure so that they come into the other side of the 65%. If that cannot happen, then why don't we then have a commission that will be able to hire and manage, but then that can sit very well with the counties? And we had structured that. We presented before the BBI team during the time of BBI, and we said a health service commission does not mean that now we are going to centralize health services. We can actually still have the counties run their functions, but then when it comes to employment, so that we only have a commission that is not restricted by the PFM Act. We have a commission where if, let's say, Nairobi or Kisii County wants to employ, it will send a request to the commission and say, I need 10 nurses, I need 20 clinical officers, I need medical
and the commission now can?
The commission hires, sends to that county as per their needs. Then within the county, they can manage them within the county. You can transfer, you can discipline, you can do whatever. When they need to move from that county to another, they apply back to the commission so that the commission can take them to the other and probably exchange. When they need to terminate, you also take back. It is possible to do that.
Yes, it is, but also it will also ensure that the needs that each county would have, because you cannot say all counties have the same need.
True.
That it is understood and in that manner also balanced. See, people who want to go back to that centralized system look at it from the time when all this was centralized, and the idea was everyone can benefit as a result of this. Because with the current system and the way it goes about it is, if you come from a community or you come from a county where very many people have gone to school or have trained as clinicians, you have an advantage. You will have more clinicians. If you haven't, then Yeah, I think you know.
Then you will not have.
No, well, you'll have a problem.
Yes.
You will have a problem.
Yeah.
You will employ, but you're going to have to supplement it by employing from others.
Yes.
And yet, what you then have is a situation you probably don't want to create where people assume that any position that is vacant must be filled by somebody from their community. You see? Now, you cannot do that to health service, because then you will disadvantage very many communities in this country. Yes.
The hope is, as you continue to have such engagement, is that there, it will fall on listening ears. So that would be the next question: is that who's listening now? And that, with the developments that we've seen over the last, few hours, you had a meeting this morning as well, but where are we now?
Since we started the strike, we had had quite a number of meetings with the CS Health, with the PS, with the Council of Governors. And the issue of SHA has been resolved. As we talk, they're inputting the data. I think some of us now can be able to use SHA. And we are told by the end of the week, everybody should be able to do that. So we can say that is being resolved. But on the issue of the breach of return to work agreement, we have agreed. We suspended our strike yesterday after an agreement that within the next 21 days, we will be able to finish and sign off on the CBS, both at the national level and the county level. And also implement the other things in terms of promotions. And you can imagine within the few days that we have been there, a few counties are already almost done with the promotions and redesignations and the other things. So you wonder, do you have to wait for us to go on a strike so that you can effect something that you would have effected without having to disrupt
It would appear
services?
so.
Yes.
It would appear so, because even the government that preceded this one seemed to have had similar hearing problems.
True.
Yeah, because you are told, it is repeated, and yet you are determined that you will only hear when you have a gun to your head.
Yeah.
Yes. It seems that is the path that they have chosen, because the alternative has always existed.
Yeah.
So you always ask the question, why do you wait until the water is boiling?
Another question would be, health is a fundamental right in the Constitution. It is what all of us ought to receive at any given point. And when we have 100 strikes, now we're going to the 101, you've not been listened to, begs the question, why does it seem as though the leadership that has been there, Uhuru Kenyatta, now William Ruto, are not taking the responsibility of giving healthcare to Kenyans as a matter of priority? Is it not a priority to them?
It's a priority in conversation.
In conversation.
Yes.
And in manifestos.
Yes. When it is spoken of and it's written down, it is a priority.
It is a priority.
When you talk about primary healthcare, there is a process that began quite a while back. It was called the Integrated Community Case Management. Research was done on it. It was understood. There's even an implementation document where the minister said, this is how you want to. That is supposed to take care of primary health care, even at the community level. Now, the cost of actually implementing it was even worked out and piloted. So it is known. So you actually wonder, wait, counties have money for all manner of things.
Yeah.
This is something, okay, let me take a few steps back. What it demonstrated was that you could reduce the attendance of patients, the hospital attendance, by 75%. Now, the pilot was on pneumonia, malaria, and diarrhea. Okay? Just those three. But it was proved that 75% of people who would ordinarily have gone to hospital because of this could actually be managed at that community level. Now, you want to ask, why do you wait for people to get to that level? Because it's going to cost you more. The condition that began and could have been managed very easily at that level now becomes serious. This person has to be actually hospitalized. They have to be given medication that they probably need to be given at the very beginning. This is a story that seems to permeate our healthcare process, because, by the way, when I say it has been documented, the ministry has documented all this. There's even an implementation plan. So you wonder, okay, why haven't you implemented it? Because you clearly understand it. And by the way, the implementation plan that is current is the year 2022 to 2027. I would like someone to tell me how the implementation is going on. Yes.
Yeah.
Because this very thing we're discussing here about SHA would have been taken care of with this.
And there are very many of those policies you're talking about.
Yes.
Other countries like Rwanda has borrowed, and they are doing actually better than ourselves. But just imagine that as we sit here, we don't have the public health officers taking samples of the water from the wells where communities drink from. We do not have public health officers going around and looking at the rivers where people get their water from. We do not have nutritionists and clinicians or nurses going to schools and looking at which child has malnutrition.
Yes.
Look at the cases of rickets.
Yeah.
Why is it that, if you find a child that comes repeatedly with pneumonia and diarrhea and vomiting, if you evaluate them well, you're going to find that they have rickets.
Yes.
Meaning, rickets is a kind of malnutrition.
Yes.
It's a case of calcium and vitamin D.
It's like a manifestation of that malnutrition.
Yes. And of course now lowers the immune and they come with other conditions.
Yes.
So if some of these things, if we had what we call the community health programs and the family health programs at the preventative or the community health level, these are things you'll be able to pick at home. These are things you'll be able to pick in school. You'll be able to correct them before they get to that stage. And as you said, 75% of those patients will not come to the hospital.
Because you've prevented it at that level.
Yes.
And you've been able to look out for what it is. So, I mean, it is clear that when we started this conversation, we talked about the fact that, you're going to put your money where your priority is.
Yes.
Right? And your priority doesn't necessarily mean that that is what it should be.
Yes.
Your priority could actually change. So if we looked at health and we say that preventative health is where the world is going, where anybody should go. It's cheaper, it makes more sense. On the whole, it comes together better. But curative is where most of the money goes. But look at what you're talking about now. Clinical officers best placed to do certain things when it comes to preventative health, which is the cheaper option and the more holistic one. How do you get folks to see that? I would imagine that they do.
Now, you see, people restructure systems to suit their interests because in no uncertain terms, right now, we are in a curative system. Let nobody lie that we're in a preventative system. Even the CHPs that we got, that we say that they are there to prevent, they are just there to scout for those people who have diseases so that we can cure. So they are just as a facilitator of the curative system. And we must be able to restructure. And the funny thing is that when we raise these voices, some of us, we are seen as if we are opposing. Instead of people saying that we are giving positive criticism so that we can be able to better healthcare. And I think what we really need a leadership that listens, that can be able to bring the stakeholders to discuss the fundamental issues about the structure of our healthcare. We start from there. Let us forget about the funding and whatever else. Let us sit down and look at how do we need to structure our health system so that it works for us. Because the health system, the kind of health system we have right now, does not work for us. Yes.
So, in the next couple of days, what do we hope to see?
In the next 21 days, our expectation is that we are going to have a CBA. All the counties will have promoted, designated. We will have a medical cover. We will have a budgetary allocation for absorption of UHC, harmonization of their salaries, absorption and payment of their gratuity. We have already written to the Treasury. I think the budget policy came out and they were receiving inputs.
Yes.
And funny enough, we realized there was no money for UHC, yet their contract is ending next year. So we have written to the Treasury. We have written to Parliament on the same. But of course, if after 21 days that does not happen, we'll be back on the streets.
I hear you. One can only hope that, the listening ear will actually then give to the doing hand, because that's what needs to happen if we're really talking about getting a health system off its knees to standing on its feet and, taking a walk. Peterson Washira, the national chairperson of the Union of Clinical Officers, has been our guest this hour. Let's see what happens as the next few days unfold. Asante Sana for being here this morning. And thank you for being part of the Situation Room, Kenya's biggest conversation this Thursday. God willing, we meet again tomorrow. It's 10 a.m.
Hi, and welcome to Shop.Digga, where we bring you the best deals in fashion, tech, think gadgets and gizmos, think kitchen appliances, think your Christmas movie, all in one stop. All you have to do is scan the QR code and shop till you drop. Remember, Standard Courier brings you all these goods that you buy at the convenience of your doorstep. We bring you the best deals, unbeatable deals this side of the Sahara. We are on TV every Saturday from 6:30 p.m. EU on Shop.Digga.
This is KTN. The following program has been rated GE. It is therefore suitable for general viewing.